Okay. Good morning, class of 1975. I hope everyone is doing well. Today, we are pleased to feature your classmate, Wendy Epstein, MD. While at Barnard, Wendy was an anthropology major whose senior thesis explored group and maternal primate behavior. She continued her education at Princeton, where she received an MA in biology, researching the endocrine regulation of sexual behavior, and then went on to graduate from Columbia University Vagelos College of Physicians and Surgeons in 1983. Wendy is a board-certified dermatologist since 1987 and for 35 years taught medical students and residents as a faculty member at the New York University School of Medicine. Currently, Wendy is the co-founder and chief medical officer of GTO Pharmaceutical, LLC, which is sponsoring a clinical trial for topical FDA-approved botanical drug for the treatment of postmenopausal women's sexual pain. She is an adjunct assistant clinical professor of dermatology at the New York University School of Medicine and has also spent the past 20 years as the health officer of Grandview on Hudson, New York. A few notes on the functions of this webinar. Everyone is muted and any chat features have been turned off. When it is time for Q&A, you can submit questions via the Q&A chat box found at the bottom of your Zoom. Now, without further ado, welcome Wendy.
Okay. Oops. All right. Greetings, and let me go back one slide. I want to welcome fellow classmates, Barnard 75. It's our 45th reunion. It is a pleasure to speak with you. I hope that I get to know many of you who I didn't get to know in college better than in the future. And I just want to give a disclaimer that let me just minimize my box here. Okay. So the webinar is intended for informational purposes only, and I'm not giving you any medical advice individually, so please consult your personal healthcare providers for any medical advice. So we're talking today about demystifying sexual pain in women affected by cancer. Now, my daughter said, "Mom, you got to speak about the elephant in the room." So there are actually more than one elephant in the room. And sexuality, for talking about women's sexuality, certainly is something that many women do not feel comfortable talking to others about. And also about cancer. That's a elephant in the room. I've had both breast and ovarian cancer. Last one was a real kicker. And talking about that in all the ramifications of having had or been affected by cancer, either for ourselves, for having gone through cancer, or having been survived cancer, or, that's okay, thank you, having survived cancer, or having loved one who has cancer, or just fear of cancer because of a family history. And the other is that I, as many of you are, I'm sure, concerned for our country during a pandemic, particularly. So while the importance of male sexual function is already proven out by research dollars and social acceptance, female sexual function is not. From the Manifesto on the Preservation of Sexual Function in Women and Girls, women with cancer, we value our sexuality. Cancer and cancer treatments can impair female sexuality. Patients want to preserve their sexuality, but we rarely ask for help. Research is needed to establish the effectiveness of treatments for female sexual problems in the context of cancer. 1 out of 3 women will be diagnosed with cancer in her lifetime. 40% of women alive who have had been affected by cancer have had cancer, breast cancer. And while menopause affects sexuality, cancer exacerbates these effects. So both menopause and cancer overlap in what they do to female sexual response and to female sexual pain, estrogens and androgens are the main cause of this. They decrease gradually during menopause, but abruptly after an oophorectomy or when your ovaries are removed, as I have had, or if you've had breast cancer, and many, many women are recommended to go on what are called aromatase inhibitors. And aromatase inhibitors inhibit the body's own production of estrogen, so even a lower level of estrogen. The consequences of the withdrawal of estrogens and androgens are vaginal dryness, decrease in lubrication, and sexual pain. And more of the sexual pain is coming from the vulvar area versus the vaginal, but you can have vaginal and vulvar pain simultaneously. There's also a decrease in arousal, which are pleasurable genital sensations. We're not talking about interest, thinking about having sex. We're actually talking about your ability to feel sexual pleasure. And orgasm, it can take longer to get to orgasm, and there can be less of an intensity. This is one case where we don't want to flatten the curve. Now, the vaginal sources of estrogen, of sexual pain, come from the atrophy, the thinning of the vaginal walls. And in extreme cases, there's vaginal tearing from the shearing forces of penetrative sex. There is less vaginal lubrication. Less fluid goes into the vagina during arousal. So we walk around, vagina may be dry, may be a little wet, but during sexual arousal, there's an active flow of fluid into the vagina. And there's less of that during decrease of estrogens. Bacterial vaginosis can also accompany or cause sexual pain, and that's because of the changes in the skin lining the vagina. It no longer sloughs off, and that sloughing off, constant sloughing off of those brick layers of skin, if you will, that constant sloughing off gives fuel for the lactobacillus, normal bacteria found there. Well, in the lack of estrogen, that brick layer is really thin and it doesn't slough off a lot of skin. And so there's a change in what's called the flora and fauna, or the bacteria in the vagina, which can lead to pain. So want to orient ourselves. Many women don't know where their vulvas are, and many gynecologists involved in our clinical trial have to educate women with a mirror because some women have never looked at themselves in this area. The vaginal opening is a dark circle in the center. To orient you, the urethra, where the urine comes out, is a little gray area with a hole in above it. And directly above that is the clitoris with a clitoral hood. The vulvar vestibule is the light pink area that surrounds the opening of the vagina. Most postmenopausal women with sexual pain have pain in the vulvar vestibule. It was a very excellent study done by Martha Goetsch. The references at the bottom. Vulvar vestibulodynia, vulvar vestibule, dynia meaning pain, is typically located in the area that's in a U-shaped area called the posterior fourchette. And that area is where typically, not exclusively, but typically women with vulvar pain or vulvar vestibulodynia, or pain with penetrative sex or with manipulation or masturbation or with sex toys, that's where pain is felt most commonly. And postmenopausal women can have significant to severe vestibulodynia, just being postmenopausal without the normal level of estrogens. Women on aromatase inhibitors, again, those are the drugs that are given for women who have had a history of estrogen-sensitive breast cancer, or after, and it inhibits the production of estrogen, or after the removal of the ovaries, oophorectomy, can have significant to severe vestibulodynia. Their sources of estrogen have been greatly reduced. It's just to illustrate, more pain can be there, more significant to severe pain can be in the vulva vestibule, called vulva vestibulodynia, vulvar pain. Now, vulvus vestibulodynia is the main source of sexual pain for most women, whether they're postmenopausal or whether they are post-cancer treatment or during cancer treatment, whether they have whatever cause of loss of their estrogen. And the proximal cause of this pain is an increase in sensory nerves in the vulvar vestibule. They're called unmyelinated afferent C fibers. And I was told by my children, my husband, to not put such technical terms, but I put it because you'll see there's a parallel with these nerves and nerves that are also responsible for another function. So less estrogen causes an increase in sensory nerves in the vulvar vestibule, and this is shown by biopsies. There's also less fluid from the minor vestibular glands. Those glands are the glands that surround the outside of the vagina. Now, it's a fascinating, I just heard a lecture from Ishwish, and it is fascinating that for a male to female transsexual, where they create an artificial vulvar vestibule, that then female, transsexual female, male to female, can get vulvar vestibulodynia, which is identical to what we see in women. And the reason is that the same tissue that forms the inside of a male urethra is identical to the vulvar vestibule in a female. And those of us who've done biology or know that during embryology, the vulva is common to both male and female fetuses until the influence of androgens or testosterone, and there is a closing up of the inner lips of the labia minora, to form the male urethra. So if in a surgical operation to make a male to a female, those are opened up, that area is vulnerable and there is an increase in those sensory nerve fibers, causing vulvar vestibulodynia. Now, pain versus pleasure. Was it pain or pleasure? Well, the same nerves, the sensory afferent unmyelinated C fibers that carry sensation of pain also carry sensations of pleasure. The same nerves that are causing pain also carry sensations of pleasure. There are syndromes called persistent genital arousal disorder, where a woman is unable to not feel sexually aroused. And it is annoying. So that no matter how many times a day one masturbates, there is always a persistent feeling of genital arousal. Vestibulodynia and persistent genital arousal disorder have in common an aberration. Something's wrong with those sensory afferent unmyelinated C fibers. Sensations of pleasure, therefore, can mitigate sensations of sexual pain. And this is so important. It's so important. Think about it. In order to address sensations of pain, you also have to address sensations of sexual pleasure. When I was at Princeton, there was a lecture being given by a postdoc about his research about taking a glass rod, inserting it into the vagina of a rat, and stimulating, in his mind, stimulating the rat to see how the threshold of pain would be on the rat pine paw when they electrically stimulate it. This is why I left graduate school, eventually went into medicine. But I raised my hand and he said, okay, if you stimulate the vagina with a glass rod, guess what? We can raise the threshold which that rat is going to actually respond by withdrawing that hind foot from pain. So after the lecture, I raised my hand. I said, well, really any woman knows that if she masturbates during menses, when she's having menstrual cramps, you can alleviate the cramps through orgasm. After orgasm, the cramps come back. But there was silence. There was no reaction to that. And I knew that this was not going to be where I was going to stay. Well, Deborah Cody, a colleague, Deborah Cody is a dear colleague and also physician, gynecologist, very well known, wrote many articles and books about sexual pain. Deborah actually passed away after 9 courageous years of battling breast cancer. She had very late stage breast cancer at the very beginning, and she survived 9 years through just her own tenacity and working at it, and good fortune. So sexual pain, according to Deborah, can and may preempt sexual desire, wanting to have sex, knowing every time you're going to have sex it's going to hurt, arousal, your ability to actually physically feel sexual pleasant sensations, and orgasm. But sexual pleasure, feeling positive sexual sensations, can lessen sexual pain. So increasing sensations of sexual arousal should be the part of the treatment of sexual pain. So what I wanted was a safe, topical, safe, effective treatment for all postmenopausal women with sexual pain, those who've been affected by cancer and those who just had decrease in their normal hormonal levels. So a topical, safe, effective treatment for postmenopausal women with estrogen-sensitive malignancies, including those taking aromatase inhibitors, where estrogen was blocked from being formed at all in the body. Also, for women who were getting a benefit, were able to use topical estrogen, but they were still having pain in that vulvar vestibular area, despite the use of topical estrogens. And it is very common because vulvar vestibular pain is the most common cause of pain in postmenopausal women. So they may be getting benefit from the estrogen thickening the vaginal wall and have less discomfort or more lubrication in the vaginal area, but they were still having vulvar vestibular pain because there's an increase in those afferent fibers, those nerve fibers, those sensory fibers. So there are also, for women who want to maybe to reduce the amount of or frequency of the estrogen use. I also want a treatment that be used as an as-needed basis. Didn't want to have to use it when you didn't want to use it. So you could use it and then start to use it again. It starts to work again. And it was a treatment, I wanted a treatment that would increase sexual arousal because that will further decrease sexual pain. And there is a reason why a drug that increases sexual arousal decreases pain, and decreases pain increases sexual arousal. What I knew, and I knew this from the literature, that systemic catechins, syncatechins, which are catechins derived from green tea, are anti-proliferative when they're systemically given in breast cancer, and there are clinical trials about that, and also has been shown in ovarian cancer in vitro to be anti-proliferative. And topically applied in cervical dysplasia, they can reverse cervical dysplasia. So we're dealing with a drug, syncatechins, made from green tea, that the active molecules, the catechins, of which one is the most active, called epigallocatechin gallate. Didn't even put it on there, but you can look it up. That drug I tried with self-experimentation with topical, the FDA-approved topical 15% syncatechins ointment. And that is on label to be used 3 times a day in the external genitalia. But it was a drug that was approved for there, and I had thought about the mechanism of action, why it might work. Well, for me, I noticed for the first time in many years, it eliminated sexual pain. It eliminated pain that I felt in the vulvar vestibule. And I would always get a check, is it really gone? Digitally check, was it really gone? Yeah, really gone. If I stopped using the drug, eventually that pain would start to return, but I've been using it for 6 years, so it goes, I don't have to deal with it. It increased lubrication. It increased it with and without arousal. So during sexual arousal, I got the kind of vaginal, it's called vaginal sweating, that I had not gotten before. So it wasn't just a matter of lubrication from those minor vestibular glands outside the opening of the vagina, but it was also in response to sexual arousal. It increased my sexual arousal. I said to my husband one day, you know, I'm kind of feeling something that I haven't been feeling for a long time. And I think it's the drug. And sure enough, that is what it does. And it's almost like if I don't use it for a day or so, and then I notice it. And increase in orgasmic response. So the latency to orgasm, as well as the peak of orgasm, was also increased. The first three effects more consistently than the last. So I decided I wanted to bring this to the greater good. And so I started a clinical trial for postmenopausal women with sexual pain. And when I talk about GTO Pharmaceutical, that's two people, myself and another person. That's it. It's not a huge company. It's just us. So the studies to investigate the efficacy of 10% syncatic ointment for postmenopausal women with sexual pain, with vulvar pain. And that included women who were using estrogens, that women who absolutely could not use estrogen, that's where we started. So women on aromatase inhibitors or women who had a previous estrogen-sensitive malignancy, that's where we started the trial. Because I wanted to show that for those women, that was safe. It does not change what's called the vaginal maturation index, so it does not act as an estrogen. And in fact, as the literature will show, it's anti-proliferative in the estrogen-sensitive malignancies and actually helps against estrogen-sensitive malignancies. In order to qualify, if people qualify, they're screened by our clinical trial coordinator. And to qualify, there's 3 in-office visits, seeing a gynecologist over a period of a month, 4 weeks, while using the topical 10% syncatic ointment. So I found that 15% might irritate people, so we start with 5%, went to 7.5, but we heard the best place was, a sweet spot was 10%. And either the patient will either get a botanical drug, or which is syncadicins, or they'll get the placebo. And people are compensated for their time and travel. Investigators, including board-certified gynecologists on the faculty at NYU and Mount Sinai, and sites are in New York City and in Rockland County. So, where 15% syncadicins is an FDA-approved topical botanical drug made from green tea catechins. We're using 10% syncadicins, and we've seen a decrease or elimination of vulvar vestibular pain on the outside area of the vagina, an increase in lubrication, both around the outside of the vagina as well as during sexual arousal, and an increase in sexual arousal. And in some, and it's earlier to tell, the orgasmic intensity. Now, since started this research, really about 6 years ago, others have shown that topical syncadicins derived from green tea significantly reduce sexual pain in a woman's vulvar vestibule. And there's a reference below. These were women who were postpartum and had sexual pain sexual pain, but pain in the vulvar vestibule, and independent of the wound healing. So it helped the wound healing, but independent of healing the wound of the episiotomy that they had, it statistically significantly reduced pain in the vulvar vestibule, because it affected those afferent C fibers that we talked about. If you want more information about this placebo-controlled, double-blind clinical trial, it's listed on clinicaltrial.gov, and you can go to gtopharmaceutical.com, and you'll have links also to clinicaltrial.gov, and it just explains a little more about the nuts and bolts about who would qualify and how if a person was able to join the trial. This is the reference that I mentioned from Deborah Cody and Vanessa Kennedy. This is an excellent review article for women, for sexual health of women affected by cancer, and focus on sexual pain. And she uses the term affected because um, some of us have had cancer, some of us are continuing to have cancer, dealing with cancer now. Some of us have loved ones who've had cancer. Um, so some of us worry about getting cancer. So it's women affected by cancer. I thought it was very good terminology that she came up with. But excellent article. So I thank you. I thank you and for the opportunity to speak with you. And I really do hope to get to see you and meet many of you that I haven't seen for 45 years, some of you. Thank you.